Hi guys, welcome back. In this video we shall be talking about postpartum hemorrhage. The incidence of postpartum hemorrhage is around 5 to 7%, okay? Now what is the meaning of postpartum hemorrhage? The meaning of postpartum hemorrhage is any bleeding from the genital tract after delivery that is known as postpartum hemorrhage. The bleeding can be from vagina, can be from your cervix, can be from uterus. It does not mean only bleeding from the uterus. Any bleeding from the genital tract, okay, after delivery, that is known as postpartum hemorrhage, okay. If this bleeding occurs before 28 week of gestation, then this type of bleeding is known as abortion type bleeding. And if the bleeding takes place after 28 week of gestation, that is known as antepartum bleeding. And the bleeding that takes place after the delivery, that is known as postpartum hemorrhage. Remember, during delivery there is bleeding. All bleeding is not postpartum hemorrhage, okay. We have a criteria to say, okay, this is postpartum hemorrhage, this is not postpartum hemorrhage. If you are doing a normal delivery and there is loss of more than 500 ml of blood loss, that is known as postpartum hemorrhage. Or you are doing a cesarean section and then there is loss of 1000 ml of blood loss, more than 1000 ml, more than 500, more than 1000 here, okay. Then that is known as postpartum hemorrhage. Remember, this is not very accurate. Why? Because if there is a very healthy female, very healthy female, and even if she loses around 500 ml of blood loss, she is not going to have a significant effect. Whereas if there is a very lean and thin woman, like she is not eating properly, she is malnourished, she is underweight, even if she loses around 200-300 of blood loss, she might go in complications, okay. So the more better one is that hemoglobin loss of more than 1 gram percentage, then you say it is postpartum hemorrhage. This is more accurate, okay. Hemoglobin loss more than 1 gram percentage, that is considered as PPH, okay. Or any bleed that compromises the patient's well-being, any bleeding that is compromising the patient's well-being, that is also known as postpartum hemorrhage. You deliver the baby is fine, mother is fine, go home, normal case. You deliver the baby might land up in complication, mother might land up in complication. Mother's vitals are not stable, mother had went to shock, or mother needs to be admitted in the ICU due to blood loss. Then you also say there is postpartum hemorrhage, okay. Now you have to remember what is active management of third stage labor. You are having 3 steps, okay. Control cord traction, injection of oxytocin, and uterine massage. Now what is this control cord traction? After the baby is delivered, the uterus is going to throw out your placenta normally also, but we never wait for the body to throw out itself, because we don't want the bleeding phase to be more longer. We do it ourselves only, okay. So what we do, we use 2 hands. One hand we are holding the cord, okay. This is the uterus, this is the placenta, this is the cord. We hold the cord and slowly pull here. At the same time, we are going to put the another hand on the abdomen of the mother, try to feel the fundus of the uterus, and we are going to give a counter traction, and we are going to pull it like this. So we are going to pull in this fashion, okay. We are going to pull, not very aggressively, very gently. We are going to pull. Okay, it's not coming, I will wait for 1-2 minutes. Again we will pull, again it's not coming, we will wait for 1-2 minutes. So we are giving a counter traction, and we are also pulling this way. This is known as control cord traction, and you have to do it slowly. If you do it very aggressively, the uterus might fold itself. That means there may be inversion of the uterus, okay. That is very dangerous thing that can happen, okay. So we want to do it very slowly. After this, we will give you oxytocin. We will give you oxytocin 5 to 10 international units, okay, IV, okay. Along with this, we will be doing a uterine massage. We will enter the hand from the vagina, cervix to the uterus, because the uterus is very big, very easy to enter the hand, and we are going to just massage the uterus. This is very effective, because it is going to constrict the uterine muscles very effectively. The uterus muscle is like crisscross fashion. Imagine this is the blood vessel, and my fingers are the uterine muscle crisscross pattern. As these muscles are crisscrossing, and they'll come together and they'll compress the blood vessel, and the bleeding will be reduced. Now let us see what is the cause of PPH. What is the cause of PPH? The very common cause is atonic uterus. 80%. This is the most common. Atonic uterus means the uterus is not having tone. After the delivery of baby, the uterus should contract, okay, to reduce the bleeding. The uterus is not contracting, okay. That is very important. Now if you are having a twin pregnancy, remember Just after the delivery, the uterus is at the level of umbilicus or just below the umbilicus. In twin pregnancy, the uterus is more bigger as compared to the single pregnancy, okay? So the uterus will take more time to become small, and then contract as compared to a mother who is having just one baby during the delivery, okay? That is the time also, twin pregnancies, there will be more bleeding. Again, along with this, if you if you have a large baby, okay, if you have a large baby, that can also cause the problem. Now, if you're having any trauma, this trauma can be due to laceration or by episiotomy, that can also cause you bleeding. Along with this, there is coagulation defects. This means there is problems in coagulation factors. The liver is not functioning, so that also there will be bleeding will not stop. So that is the reason you should do a bleeding BT and CT, bleeding time and clotting time. You should do it always before any surgery, okay? And retained bits of placenta. If the placenta is entirely not coming out and there's a small bits of placenta, this placenta is very rich in blood and they can be infected very easily. And once they infect the bits of placenta, it is going to infect the entire uterus and there will be excess amount of bleeding. So if today the lady delivered the baby, if there's written bits of placenta, the patient will come after around 7 to 10 days saying I'm having very good amount of bleeding. Okay, so you have to remember two things. If there is bleeding within 24 hours after delivery, that is known as primary PPH. And if there is bleeding after 24 hours till 12 weeks of delivery, that is known as secondary type of PPH. The cause of secondary type of PPH is retained bits of placenta, okay? We don't want to have retained bits of placenta, okay? How do you know there is placenta is entirely has come out or not? If you see the placenta, it will be a very smooth margin. There will be no defects in the margin. If there is written bits, there may be a defect in the placenta, somewhat like this, okay? So you have to see the periphery margin of the placenta, okay? Now let us go for the management. How will you manage? The first thing is that pre-preparation. That means before doing any management, if you did these three things, no, control cord traction, injection of oxytocin and uterine massage, there's very less chance that you will have PPH. But let's say you didn't do it or there's some reason there is bleeding. Now what you are going to do? The first thing is that you're going to call for help because you yourself alone cannot manage the case. You need nurse, you need special doctors, more experienced doctors, okay? So you're going to call for help. Then you're going to give oxytocin. Now you're going to increase the dose, 10 to 20 international unit IV, okay? You're going to give this. Now even if this thing fails, then you're going to go to give methyl argometrine. Remember, you're going to give oxytocin only when the baby's anterior shoulder are out, because sometimes it happens that baby's head comes out but the shoulder is getting stuck, okay? And that is known as shoulder dystocia. And at that time, if you give oxytocin or something, the uterus will contract very severely. The baby will come out very forcefully and the baby's shoulder might be damaged. The baby might be having fracture or the brachial plexus can be damaged, okay? So you don't want that to happen. So after you see the anterior shoulder are out, then and only you're going to give oxytocin, okay? Even after giving oxytocin, if it fails, then you're going to give methyl argometrine. It's a very, very good drug. You're going to give 0.2 mg IV, okay? Now, once this thing is done, if still this thing fails, then you're going to go in this step. But before that, I would like to say, what is the side effect of methyl argometrine? If there's a twin pregnancy, if one baby is out and you give methyl argometrine, the uterus is going to contract immediately. Uterus is contracted, that means no blood supply to the placenta. No blood supply to placenta means no blood supply to the second baby inside the uterus. So the baby will have hypoxia. And if it is Rh negative case, let's say if the mother is negative, Rh negative, and the baby is Rh positive, okay? If you give this methyl argometrine, there will be sudden spasm of the uterine muscles. The blood which is present in the uterine cavity, okay? Remember, the blood of the fetus and the blood of mother is never mixed, okay? And during only delivery, then only it has been mixed. So we don't want to give methyl argometrine here, because it is going to contract very severely, and because of that, some of the blood that can forcefully enter the uterine veins, okay? So now we are going to give methyl algometrine. You are going to wait and watch and let the body to contract itself and all the blood that has been mixed here to be thrown out of the body. If you give methyl algometrine, it is going to contract so aggressively, some blood might come out, some blood might even go in back direction and enter the uterine veins. Okay, so now the mother is going to have a antigen. Okay, now for that again mother is going to make antibody, and that antibody will be rotating in her system. Next time she has a baby and that baby is positive, now the antibodies of the mother will come and attack the babies plus. Okay, if the baby is A positive, okay, and the RBC will be ruptured and the baby may even die. That is a very big problem. Okay, along with this, if the mother is having hypertension, if you are giving methyl algometrine, around 1 liter of blood goes back to the circulation, so the blood pressure might go increase. And if the mother is already having heart issues, what will happen here is that if you are giving methyl algometrine, again around 1 liter of blood will go to circulation. It will put a lot of pressure to the heart. The mother might be having congestive heart failure. She might land having congestive heart failure, or she might be having pleural effusion. Okay, so we don't want this thing to happen. Now after this thing also, if it fails, then we are going to come to this drug. Okay, now remember this drug is given in the rectum. Okay, it is not given in the vagina. You can give in the vagina, but if you can give in the vagina, there is bleeding and this drug will be washed off. So you give in the rectum, and the advantage of giving in the rectum is that it will bypass the first pass metabolism. Okay, what is the dose? 1000 microgram. Okay, still this thing fails, then you're going for the next drug, Carboprost. Okay, you're going to give 250 micrograms and you're going to give only in IM, intramuscular. You're not supposed to give this intravenous. If you give this intravenous, there will be sudden rise of high blood pressure. Along with this, you can add fibrinogen to help the blood clots to coagulate better, and balloon tamponade. What you do is that this is the uterus, no? You enter a catheter that is having a balloon, and you fill the balloon with fluid, saline. Okay, and you put around 500 ml. So it is going to put pressure to the uterus and it is going to stop the blood bleeding. Okay, this is very effective, balloon tamponade. Still this thing fails, still this thing fails, very unlucky case. Still this thing fails, then you have to go and save the patient by doing surgery. Okay, then you are going to give brace sutures. Now what is brace suture? Okay, unfortunate case, then you are going to go for this surgery. Okay, so what we are doing, we are taking a suture, we're going in this fashion, making a twist, we'll tie it somewhat like this. Okay, we are tying the suture in this kind of fashion. Okay, and then we are going to tighten up this suture so the uterus will contract in this fashion. Okay, and the bleeding will be stopped. Still fail, then we are going to go and do uterine artery and ovarian artery ligation. Okay, remember, we are not completely shutting off, we are reducing the blood flow. We are not completely shutting it down. Still fail. At that time, it is more important to save the mother. That time we are going to do a hysterectomy. Okay, because the life of the mother is more important than the baby. Okay, so we are going to do an hysterectomy. We don't want to do hysterectomy because we want the mother to have another baby, but we don't want to put the life of the mother at risk. So the life of the mother is always at the highest priority. Okay, we'll save the mother. So at that time you will be doing hysterectomy. Okay, so that is about postpartum hemorrhage. Remember the active management and this management. If you do the active management very well, chances are less that you need to do all this, but yes, still you have to do. And remember, if there's any bleeding, the mother may go in shock and all that. At that time you have to do ABC, airway breathing circulation. Okay, use a thick gauge of needle to set up an IV line. You then arrange for blood, do cross match and all those stuff. Okay, that is emergency protocol that you have to do for life saving of the mother. Okay, that's all for now. Thank you.